Okay, so iliotibial band, how do we assess it? And it does go under the radar, there's no doubt about it. This is my go-to assessment. We call this the OBIS test, and I've sort of modified it a little bit. There is the modified OBIS test, but I've actually even modified it even more. But this is how I assess it. So the hip and the knee need to be in line, and the knee and the hip need to be at the same height, as does the ankle. Okay, so we're going to be at literally about 90 degrees here. The idea is we're holding the knee here, and then obviously we're letting go. All right, so if we're getting a drop with the knee towards the table, then that will indicate that the ITB is not tight. So if we're with Candace here, let's just say hypothetically that we let go and it drops to about here. Okay, we can suffice to say that this ITB is quite tight. If it drops down towards more to the actual table itself, then we know we haven't got a really, really tight ITB. It's a broad assessment, but it's a good indicator whether or not we're dealing one. Obviously, like anything, we have to assess both sides. Okay, so it is imperative that you're assessing both sides. This is not about provoking pain, this is more about a range of movement and just getting a bit of an idea of what the tension is onto the ITB. And this is where it all comes back into treatment, because we use this to gauge whether or not we're getting a change. So as I said before, a lot of this condition, or if not all of this condition, happens in and around the hip itself and restrictions of the hip itself. So that allows the band to be tight. So there are other muscles here that interplay with that as well, but this is just a broad overview and probably a really good go-to. And this is what I use in terms of assessing it, treating, and then reassessing. Okay, so that's the modified. So remember, just to recap, hip, knee, and ankle need to be at the same height. The knee and the hip need to be in line with each other as well, because if you've got the knee in here, then obviously you're going to have a greater range of movement, so there's not as much tension on the ITB itself. Okay, so that's the OBIS test. So we're going to do some treatment towards the vastus lateralis. Now we've done a lot of work, as I've mentioned and showed you, around the hip, but it is also important that we address some of the tissues down here as well. So the ITB is coming down here, obviously crossing the knee joint and obviously inserting down here, blends with the rest of the fascia here as well. But specifically this area down here, and it is directed towards the vastus lateralis, so it's important that we address this area in particular, and also the clusters of trigger points in and around this area as well. And look, in terms of how much we do, and the pressure will vary once again on the clients that we're working with. We do absolutely have to have them in knee flexion, because we're going to be working them through range of movement as well. Okay, so I like to use this area. We're going to use the Premax Original here, because it's got a little bit more of a grippy. We don't want too much slip going on, so obviously we used the lotion for the cupping before. This time we're going to use the cream, because we want a little bit of grab and a bit of grip with it as well. So we're going to be working fairly once again, nice and slowly. I'm just going to use a really, really soft, loose fist. I'm going to pick up the tissue. Now the key to this is picking the tissue up, moving it medially as far as I can, and we'll lock it out there. And then I'm going to lock up more towards the longitudinal. So I'm going to hold it about there, and then we're going to introduce some range of movement, and we're just going to work right along that edge of that vastus lateralis, a little bit on the rectus femoris, and then out towards and up towards that sort of TFL, rec fem, vastus lateralis. We're picking that tissue up there. Okay, so rolling it up, lock down, introduce a little bit of range of movement, and then we're working along the length of that tissue like so. So be very purposeful. Don't adjust your pressure, just work through it. Obviously I'm using my body weight, so I'm going through here all the way up, and then you can sort of just continue that. I tend to find I will do this probably about 6 or 7 times will suffice, and then I can move more towards the rectus femoris and come up through that area there as well. Now I will mention to you, before I start anything with ITB or looking at treating ITB, I will 100% make sure that I've cleared out the hip using the NAP protocol for the hip. It gives us a level playing field, because if we've got any altered movement patterns through there, the unfortunate situation, especially with those glutes, and if we've got the adductor that's inhibiting the glutes, well, we need to address that, because all of this treatment sequence that we do can basically not be as therapeutic or purposeful as we want. So we have to have a level playing field. So make sure you're aware of the NAT HIP protocols first and use that as your first port of call. Address all those restrictions, then come and apply these techniques and so forth.